you've heard a lot. You've heard a great deal. And I'll ask Anne to make a point, but the most important thing that came out for me in something like this 5 years out, and that is the long-term horizon. Those are 3 words he used. And in a business environment, injecting that into the equation, getting people to think that way is incredibly important. And why it's important is because if you're going to introduce anything that has a preventive component, those 3 words are essential. So again, the biggest takeaway that you can get before you even sit down, he talked about having meetings and getting together with boards. It's the long-term approach that needs to be felt and appreciated. The response to that, do you agree?
No, absolutely. And I'm an economist, so the investment case for this, and we need, if you are a public health professional, you need to convince the finance committee or whoever about whether your approach makes sense also from a financial perspective, and there you need to have the long term. It's not just appealing to the positive spirit and the good hearts of everyone won't do it. You also need to look at the economic engine behind this.
Thank you. Translation: feel good doesn't always work. And uniquely from your position, public health, corporation, working in a foundation, how do you see this? What do you think about when you bring an idea to the table, when you're following up on something? Give us some insights in how you prepare and how you work the issues.
Oh, that's a difficult one. Where to start? I would like to start by saying I very much appreciate this long-term vision you just presented, Niels, because that is what is really missing for Better Hearts, Better Cities, the urban hypertension initiative we are driving. It is we started on another foot, so you need that long-term commitment from your visionary leaders to start an initiative like this and make it in a long-term sustainable at scale. What we got as a goal for was you go and try it in 3 cities, and if it works, then we will see. But that's because we are a small foundation, we are not the company. And I think the main difference is with Novo Nordisk is the company implementing it, with your associates on the ground who do this, who sit with the different stakeholders, whereas from our side, we didn't have the company involved. And that step, that bridge towards the company is only being made now. And I think I would never do it again like that. It would be much more successful for, by definition, scale, but also long-term engagement if you do it immediately through the company. I learned that AB InBev's initiative is also, Foundation's initiative is also implemented through the company. So I think these elements are really key for future engagement in large urban initiatives. Because what we face is our senior leaders asking, isn't this too ambitious? Isn't this too bold? Are we going to have an impact on this? They prefer maybe to choose a neglected disease to have a major splash impact and be very visible there, or put a lot of resources into research for one specific disease because it's really life-saving and it will have an enormous impact even if it's for a smaller number of people. So this is the mentality in a company, having focusing there where you can be best. So this initiative to address hypertension, the biggest problem we face in every city currently, where we have prevalences of 30 to 40% of hypertension. It's really a time bomb where you have in a capital city in Africa 1 cath lab where you can do interventions for people with a myocardial infarction, for example. It is a time bomb. So it's a bit big for one company. That's why you need to work with all these partners. And that is the similarity we have between the two things. But I think you had the right approach, and I'm really very impressed with how far you already are in 5 years.
maybe I should add some color to how it is to implement it on the inside of a corporation, because that's not always easy. The key benefit, as you say, we're present in almost 100 countries around the world with what we call affiliates, so sister companies, and that is a really, really strong asset. But of course, they're different. In China, we probably have 4,000 employees. Same here in the US. But in some European countries, there's only a handful. And some of them are not equipped and have no training in or have no expertise in driving public-private partnerships. They are sales and marketing organizations because that's what they do, because they are on the inside of the corporation. So we are really, what we've throughout the 5 years, we've really been careful in when we select those places, or from our point of view, we might approach a city or a city might approach us. We've been really careful in do a self-assessment of, do we have the internal capabilities and capacity to have the long-term view, at least 3 years? Does the local management of Novo Nordisk see this as a long-term investment in building relationships rather than a short-term PR exercise for kind of a short-term win on reputation? And there are those, and we have also seen those, and they predictably fall apart. So, but this careful selection about where does it make sense? Do we have the capabilities ourselves, and also do we have the resources to fund? And I think that's a really, really critical finding. To fund the organizational backbone to sustain the effort in the cities, because many cities won't have that human resource to actually drive that collaboration. They won't be able to fund the research either. But so those are the two things that we actually fund. The actions themselves are typically done within the existing budgets already by repurposing them or finding new sources of funding. Seldomly comes from us.
I'd like to ask both of you a question, and that is, who should be sitting at the table? And who is sitting at the table initially? Does that group of people need to be sitting there consistently, or will you add different people? You mentioned finance, having to sit. I've noticed in my own work, having a minister of finance involved really can get things done that sometimes a health minister can't. And so I'd like both of you to address that if possible.
Yeah, that's the first thing we do in a city. So when we chose our cities based on the disease burden, as Jeff explained yesterday, but also based on the likelihood of success, which is based on the easiness of doing business. Let me say it like that, because if you cannot work in a city, it's useless to start in Kabul when you know it's going to be very hard. So we started in cities where we then spoke first to the mayor, and it's only when the mayor tells us, this is exactly what we want to do, bringing these different sectors together, here's my budget, let's go for it. Then we sit around the table with all the stakeholders locally, which is the city health authorities, the finance ministers, the IT companies, the insurance organizations in the companies, the patient associations, sports associations, schools' responsibilities if it's not the Ministry of Education, the Association of all employers, and many more stakeholders to bring everybody at the same level and align behind the same goal of what we want to achieve. And the difference between Better Hearts and Cities Changing Diabetes is that we did not finance the major operations. That's all domestic resources. We financed the risky stuff in there, the innovative parts of an undertaking to improve cardiovascular health in an urban setting, where the government wouldn't have the budget for. So that's a different in approach, but I guess you had around the same kind of stakeholders.
And context matters. I just give an example. Houston, I think there are more than 75 organizations in the coalition. There's a steering committee that is smaller, but then, the whole network is probably 75 organizations, public and private altogether. In China, civil society is more of a vague concept. And I just say that as a, those are the realities. And therefore you need to be savvy about what those realities are and work with that. But of course, I think for us, the criterion has always been to have the municipality on board at the highest level possible. That varies a little bit, but if we could get the mayor, of course, and then a local research institution. Research must be anchored locally. There's an element of capacity building there, but typically the local research institution will also know what the main issues are. We can, of course, work with them, and I think UCL has been really, really strong in building that bridge between the global research and the local research, but it has to be anchored locally.
One of the things I want you to take away from this is their feel. They really shared with you sort of the sensations that they were going through as they were being asked and challenged. It is not an immediate response, this will be done and that will be done. Quickly, I'll share with you a snatch from the jaws of defeat that I faced. I was called in by corporate at ExxonMobil after a series of deaths from malaria. And I was asked to cure it. My initial response was, this has been around a little over 2,000 years before Christ. I quickly looked at my numbers and knew I wasn't ready to retire. So I decided that maybe we should change cure to manage. I can comfortably tell you by implementing a program that 8 years later there have been no deaths from malaria, and there have been 4,000 to 5,000 cases that didn't occur. But sadly, I did not cure malaria. But I found a way to speak the same language as the corporation, which was to stop the illness and stop the deaths as best could be. So again, different language, good outcome, and the other thing that is most important, and I'll touch both of them when I say that, is cost. The cost for the initial testing to make sure people were compliant with their antimalarials was $200 because I had to send it on dry ice to Scotland. You are looking at the man who depleted all the dry ice in West Africa. But on the other hand, we were able to work with the French Army to develop the dipstick test, which you could actually place a dipstick in the urine specimen and immediately find out if they were being compliant with their antimalarials. So the program basically implemented a compliance program so that people took their antimalarials. And for Mr. Monahan, our lawyer in the audience, it was not a condition of employment that they take their antimalarials. It was a condition of being placed in that area. So you didn't go to an area with malaria if you didn't take your medicines, okay? So we didn't get sued for that one. But again, working in a corporation is really adjusting, managing, and working on a common outcome. And it's not as easily done as said. Would you each have a closing remark before we begin our next panel? Please, questions.
I had one question.
Two.
So it's a question to Niels about the sustainability of the financing, which you talked about. Where are the resources for that bend the curve, multi-year, maybe multi-decade campaign? And I'm thinking about local foundations that are not necessarily corporate foundations who have a global reach, but I'm thinking in the communities where the campaigns are underway. So you have 22 cities as of today. Each of them has a community foundation or a city-focused foundation, in many cases multiple. These are foundations that are tapping local resources, that often partner with cities, that often partner with hospitals and education institutions. So they have a lot of that local expertise, but they also have a pretty vast sum of money. In the United States, the community foundations, when you put it all together, are the largest source of philanthropy in the U.S. But I haven't seen them participating yet. And I don't know if that's true in the 22 cities or as part of your strategy going forward, because the sustainability of the financing of this, when we're dealing with long-term arcs, of history is something that worries me a little bit.
It's very, very true. The U.S. healthcare system is very, very scattered, and that makes anything that brings it together quite difficult, also from a financing perspective. I think when you look at smoke cessation and alcohol abuse, there are very, very strong investment cases in a municipal level for when you invest in those activities. The return on investment actually is good on the inside of the municipality. At least that has been shown in several European countries, and that's why you have the programs. Right now, we don't have the evidence for obesity and diabetes. But I think there are some movements, particularly in Europe, that are willing to look at, if we look at the context of a municipality, a Danish one, which is the one I know best, you both have the costs associated with healthcare, but also with social care. You will have the tax collection, and you will also have the benefits of productivity improvements. And so they are all on the inside of the system. So what we're working with currently is to develop that economic engine or the investment case for actually with a focus on probably some of the more either socially deprived or geographically deprived, or both, where there are also considerable social costs associated with that deprivation, and also the fact that people have diabetes. So if we work with interventions that address both the social aspect as well as the health aspect, I'm quite positive that we can show that return on investment through reduced cost as well as improved tax collection and productivity gains, that we can build that investment so we can either de-risk outside investments or simply have it funded through long-term commitments on the inside of the municipality. I know it becomes a little bit technical, but I think there's great likelihood that we can do it in a European context, and once we have, and now we are probably 2, 3 4 years out, but once we have proven that case, then there actually might be ways of implementing it in other geographies.
Did that answer your question? Any other questions? Yes, sir. Please, David. I'm sorry, sir. Okay, could you?
David Vlahov. I'm not an economist, so this may be a very naive question. But in terms of paying for programs, you talked we have to be innovative in what we've done because there are limited funds in terms of the programs that are already there. And one of the suggestions that you mentioned was pensions, going into pension accounts maybe. And I'm trying to think about what is the return on investment to a pension account. In other words, people are living longer.
Well, we have talked with several pension funds about what they would expect in terms of return on investment, and the first answer they say is 6 to 8%, considering the risk that there might be there. I think we can work with a lower rate because the general interest rate is so low, and if you have other philanthropic funds to de-risk some of the investment, it might be a possibility. So, but we, and that might be. I mean, you'll be the judge of that. Can we work with a profit motive within public health? I mean, that's what we would be doing, because we would be asking. I mean, we would give that return back. Personally, I'd prefer it if that money stayed on the inside of the municipality. But if the alternative is no action, then I'm willing to compromise personally. But we would need to work with that. Yeah.
Could I add that it might be measured in productivity, if possible, presenteeism, and decrease healthcare costs? That's where it might be measured. Sir George.
Thanks very much. Thanks very much. A couple of points. One, I'd like to congratulate you on the presentation. It really was great. It covered a lot of ground and reinforced my view that. Put this microphone on. Thanks very much. I can't read. Yeah, congratulations. You really gave a splendid account of what Novo Nordisk is doing. There's a lot of things that I would wish your comment on, but just to focus on two. You are lucky in a sense, Novo Nordisk, ideal company. You don't have to maximize shareholder value for a start. And so your foundation really doesn't have the same problem as other private companies would. I'd call it a problem other companies could do. So you can afford, in a sense, many of the initiatives. But my basic question is, for when you say to work with, I don't quite understand who you work with. And I make this point because I have painful memories of large meetings of mayors. And when you speak to them about investment cases, you're talking to them about returns over long term. And their lecture cycle is 2 years, 3 years. They're not really interested in that. So if you want to look for some entity that has a long-term future, has a long-term standing, this is why I focus so much on civil society. So my question would be, how are you working with civil society such that when the governments change, there's still that interest in maintaining their program? China is different because China, you can be assured that political interest will continue. But in democratic societies, that is not really so. So I'm enthusiastic about hearing exactly and promoting that much of this effort, and I don't believe a lot of these investment cases because I think they're good for economists, but they don't really move ministers of finance who are going to be elected in 3 years. So how do you work with civil society to ensure that continuity of interest? Specifically, how do you work with them?
Well, you make it an excellent point, and the way we work is different. Let me also just clarify one thing in terms when I say we work with. We facilitate a coalition, and typically the decision making is always at the municipal level. So it's the health mayor or the mayor or who else. They will decide. But what happens before the decision, the engagement in what is good and what might we, do now and what should we do later and how do we work with others, that we participate in as a Novo Nordisk together with the Diabetes Association, with the research institution, with whoever is around the table. But we have seen that our collaboration in some cities has changed because of change in leadership. Or because another political public health emergency has arisen, for example, the opioid crisis. And, that we just need to work within that context. I think it's difficult to do something that is not anchored in the local political process and the local decision making. And maybe the social investment case might be relevant where there's a continuity of leadership, and that's where that would be applicable, whereas you would work much more strongly through a community-based approach in other places. But it is true that when we want to engage local resources, the soccer club or the cricket club or the local supermarket owner, that's where we actually get change on the ground.
That's right.
Well, our time is up, but I want to thank Niels for, as Sir George alluded to and stated emphatically, that for a great presentation. And also, you've done a second thing. You've introduced the next section by your talk, by what you've just said. So with that, we will end, and thank you all so very much.